Hi, welcome to the full site initiation visit for the CALIBRE trial. My name is Khalid Ahmed. I'm also known as Abdul, and I'm the Senior Trial Manager for the CALIBRE trial. This SIV presentation is mandatory for any sites going live, site staff, and also for ongoing training. Although this presentation would last for around 40 minutes to 1 hour, I have broken down this presentation into 3 further small presentations for yourselves to go into and have a look at different aspects of the trial. These 3 small presentations, the first would be excuse me, screening, consent, recruitment pathways, and randomization. The second would be CRF returns and missing data. And the third would be pharmacovigilance, crossover, and withdrawal. And these further 3 small presentations are available on the CALIBRE website, where this full SIV presentation is available. So what does CALIBRE stand for? CALIBRE stands for carvedilol, which is a non-selective beta blocker, versus variceal band ligation, which is a banding procedure to eradicate any varices in primary prevention of variceal bleeding in liver cirrhosis. So we're looking at primary prophylaxis treatment for this disease cohort. And we are currently on protocol version 2.0, dated the 15th of November 2019. Obviously, subsequent protocol amendments may be needed in the future, so please do refer to the most current protocol at that point in time. So in terms of the clinical trials unit, the makeup of the trials unit, our team leader is Gemma Slynn, the CI is Dr. Dhiraj Tripathi, the sponsor is the University of Birmingham, which is the same place as the clinical trials unit, which is ourselves. And the funder is NIHR HTA Portfolio. It's a £2.3 million grant running until May 2024. So in terms of today's agenda, I'll briefly talk to you over the background of liver cirrhosis, moving on to the objectives, study design, a little about data handling, and quite importantly, pharmacovigilance in terms of safety reporting, serious adverse events, non-expedited SAEs, and so on and so forth. So in terms of the background, very briefly, liver cirrhosis is the 5th largest cause of death in the UK. On average, age of death is about 59 years. And this really causes a great economic impact due to the need for hospitalization and workforce implications. So looking at the economic impact, we have as our secondary outcome looking at hospitalizations, for instance, and the 2 different treatments, carvedilol and VBL. So for instance, carvedilol may be a very, very less expensive drug in comparison to the VBL procedure, whereas having a look at hospitalizations, for instance, carvedilol participants may be hospitalized more than the VBL patients, and vice versa. So we're looking at both the clinical effectiveness and also the cost effectiveness of the trial to have a fuller picture of our outcomes. In terms of variceal bleeding, a major complication of liver cirrhosis is variceal bleeding, and variceal bleeding has a 1-year mortality of up to 40%. The main aim of our trial is to reduce the risk of the first variceal bleed. So we're only taking participants in the trial who have never ever bled. So what's our trial rationale? There is currently a disparity in the current UK guidelines with regards to the prime prevention of variceal bleeding in patients with medium to large varices. So we're looking for participants with medium to large varices. And the NICE guidelines state that in 2016 that to use the VBL as the first line, whereas the BSG guidelines in 2015 recommends VBL or a non-selective beta blocker such as propanolol, nadolol, carvedilol, and suggests a non-selective beta blocker to be used as the first line. So the current evidence comparing the 2 treatments is based on very small, underpowered, and low-quality trials. Notably, there are 2 small studies that have been conducted within this area, One was in the UK and the other one was in Pakistan. And these are very, very small, in the hundreds. So we need a large randomized control trial that would really help clinicians like yourselves best decide what the best treatment for your participants or patients is. At the moment, it's very vague in terms of which one works best, VBL or carvedilol. So hopefully, at the end of the trial, we'll all find out through a large randomized control trial which treatment is best for our patients. So coming on to the primary objective, we want to compare carvedilol versus variceal band ligation in preventing any variceal bleeding within the first year of randomization in patients with cirrhosis and medium to large esophageal varices that have never bled. So the three key things here is we want to compare the two interventions. Both of the interventions must not have been used on these participants before, so it has to be primary prophylaxis. The second is they must have medium or large varices, and these have to be esophageal varices that have never ever bled. And the primary endpoint is variceal bleeding within the first year of randomization. In terms of our secondary objectives, we want to investigate the effect of carvedilol and variceal band ligation on survival. We want to have a look at development of other complications of cirrhosis and adverse events. We want to assess the cost effectiveness, patient preference, and use of alternative or crossover therapies. So one slide is dedicated for crossover therapies, and I'll talk to you about that in the latter few slides. So in terms of study design, it's a very straightforward randomized controlled parallel group trial, one-to-one randomization. The 12 months internal pilot consisted of the qualitative aspects. That is over now, and we are in the full phase. So we want to continue. We are continuing with the full phase. And please do ignore all the qualitative aspects of the trial. So it's in the full phase now. It's an open label trial. The two interventions are carvedilol versus variceal band ligation. As you can see, these two interventions are quite different and distinct. Hence, they're open label. We can't really blind these interventions. And we're recruiting over 66 UK sites across the UK. So the devolved nations are involved. So we have a number of sites in Scotland, one in Northern Ireland so far, and a few in Wales. We want to recruit over 2,630 participants across the next 3 to 4 years of recruitment. And there's a 12 months follow-up for each participant randomized to CALIBRE. So just briefly talking over these internal pilots. So the internal pilots commenced on January 2019 and ended in January 2020. Certain progression criteria needed to be met to continue to the full phase, such as 250 participants, over 20 sites, on average 1.6 participants per open site, and 2 sites opening per month. And we needed to have 90% of participants complete their data collection at their 6 months follow-up visit, and there shouldn't have been any safety concerns which would prohibit continuation onto the main trial. So at the moment we have progressed to the main trial. This is just a trial summary, the main trial summary. As you can see, the inclusion and exclusion criteria. This is not very clear in this slide, so I have expanded the inclusion and exclusion criteria in the next few slides to go over. So briefly, if the first inclusion criteria has been met, such as liver cirrhosis as defined clinically radiologically with transient elastography, where liver stiffness, in the clinician's opinion, supports a diagnosis of cirrhosis or on histology. So once that's met, the participant would be sent a main patient information sheet with the appointment letter. Once the participant comes into clinic, the research team would approach the participant. If the participant's happy with to take part in CALIBRE, then a consent form would be completed. And at that point in time, we would advise you to get the EQ5D5L form completed as well. And then take the participant into the index diagnostic endoscopy room to have their endoscopy performed. Once the endoscopy has been performed, that's when you would know if the second criteria of the inclusion criteria has been met, which is medium, excuse me, and or large varices that have never bled as defined in the BSG guidelines. So once the participant has had the endoscopy confirmed and they have medium to large varices, then they could be randomized to CALIBRE, providing these exclusion criteria have not been met. It's a one-to-one randomization system, and I'll talk about the online randomization system later on. So they are randomized, and the system would give you a intervention and also the trial number. So once you receive the trial number, please do retrospectively put it back on the consent form. It's a 4-digit number, and the system would give you either VBL or start them on Carvedal. If the system randomization system notifies you to prescribe the participant with Carvedal 12.5 milligrams per day, please prescribe them the 4 weeks from your site, and the remaining 11 months would be prescribed through their GP pharmacy. So a REC approved GP letter is in the site pack and also available to yourself. Please do send that to the GP with the hospital letter that you normally send, that the participant is being looked after by your team and the participant is on Carvedal 12.5 milligrams per day. There is an additional 4-week visit. This is an adverse event safety visit for the Carvedal arm only. So please, at that point in time, book in a 4-week visit for the participant. There is a plus or minus 1-week window for the 4-week visits. So you can see the participant at 3 weeks or at 5 weeks. And then there's a 6 months and 12 months visit. So please mimic the 6 and 12 months visit with your standard of care visit. So there's no additional visits for the participant. And at that point in time, please, at 6 months and 12 months, EQ5D5L needs to be completed by the participant. For the VBL arm, once they're randomized, then it's just the 6 months and 12 months. And obviously the eradication of the varices need to be performed via subsequent visits, which is standard of care anyway. So moving on to the next slide, inclusion criteria. So I've just briefly talked about the inclusion criteria, and I thought I'll expand it here. So liver cirrhosis as defined clinically radiologically with transient elastography, where liver stiffness, in the clinician's opinion, supports the diagnosis of cirrhosis on histology. And also, they need to have medium or large varices that have never bled as defined in the BSG guidelines. So these 2 criteria need to be met to be randomized to CALIBRE, providing these exclusion criteria are not met. So we're only recruiting adults aged 18 plus, so there's no upper limit of the age. They can't be pregnant or lactating women, so any mothers that are breastfeeding will not be eligible to take part in CALIBRE. If they are pregnant, they will not be able to take part in CALIBRE. If they fall pregnant within the 12 months after randomization, for instance, then that participant would need to be withdrawn, however, followed up till the end to see what the outcome of the pregnancy is. So a pregnancy notification form is on the website and also available in the site file, in your site file, and also available from ourselves. Please do let us know if a participant is pregnant, because that participant would need to be withdrawn and a change of status form would need to be completed for that participant. Anyone known intolerance or contraindication to beta blockers, including asthma, unable to give informed consent, acute alcoholic hepatitis, anyone that's current or past history of use of non-selective beta blocker, such as the ragbag, carvedilol, nadolol, or propranolol, anyone with a current or history of variceal band ligation, previous organ transplantation, presence of malignancy or systemic disease that significantly affects 1 year of survival. So we're not looking for anyone that's come to end of life or terminally ill that would pass away within the next year. Patients with surgical or radiological systemic shunts, such as TIPS, would not be eligible to take part in CALIBRE. So in terms of recruitment, a medically qualified doctor who is delegated by CALIBRE must confirm participant eligibility. So in the randomization form that needs to be completed before all the data needs to be added to the randomization system online, the eligibility criteria that I have just explained in the last few slides, the inclusion and exclusion criteria, would need to be confirmed by a medically qualified doctor that is delegated to do that duty, who is on the delegation log. We have a copy of their CV, GCP, and training log. And they have been trained on the CALIBRE slides. So there are 3 avenues or routes or pathways of recruitment, and these are planned endoscopy, outpatient clinical referral, inpatient referral. And we are not preferring any of these routes. Any of these routes could be taken. It depends on what your preference is at site and what is feasible for you at site. And I'll talk you through these pathways in more details in the next few slides. So as I say, just to reiterate again, there's no pathways that have been preferred, but which suits yourself. So only participants who have not yet started treatment will be eligible to take part in CALIBRE. So this figure is pathway 1, which majority of the sites are, have been recruiting participants by. However, this is not a preferred one. Neither of them, any of them could be used. So please use the one that's suitable for your site. So for this pathway, I'll just talk you through the steps. Please ignore the green parts where qualitative aspect of the study is recorded. So no sites are doing the qualitative anymore. This was part of the first year of the pilot, so that is over now, and no sites are taking part in the qualitative interviews. Those are all completed now. So for instance, patient with liver cirrhosis is advised of the need for endoscopy to check for viruses. So this surveillance cohort of patients on the surveillance list may have had a diagnostic endoscopy a couple of years back. So you may call them back in to see how if their varices have developed into larger varices, for instance. They may not even have a varices. They may be subjected or suspected to have cirrhosis. So we're not very sure about these participants if they are eligible or not. So that's why a index diagnostic endoscopy would need to be performed to find out if they have medium to large varices, for instance. So they are sent a main PIS, patient information sheet, with the appointment letter. Once the participant comes into the clinic, a member of the research team would approach the participant, go over the PIS. Once the participant is happy, satisfactorily, all the questions have been answered, please do complete the consent form and the consent is taken. The consent could be taken by a research nurse, a member of the team at site who has completed the delegation log, who has gone over the SIV slides and has had appropriate training to CALIBRE. We have a copy of their CV and GCP. So it doesn't have to be a clinician. It could be a research nurse or someone that your trust policies allow for them to take consent. And we have just the documents that I mentioned earlier. So once the consent's done, please get the participant to complete the EQ5D5L. Once the EQ5D5L is completed, please take the participant to their endoscopy. Once the endoscopy has been performed, obviously before that, you complete the randomization form, speeding up the process if need for randomization. And once the randomization form has been completed and the endoscopy has been performed, you would find out if they've got medium to large varices that have never bled. If they have medium to large varices, then you randomize them on the system by entering all that data in the online system. And I'll talk about the online system in the later few slides. And then the system would give you an allocation of carvedilol or VBL and a participant number. And that participant number would need to be put down on the consent form that you completed earlier with the participant. If they have small or no varices or orthopathology, for instance, then they would not be eligible for CALIBRE. Please destroy the consent form, EQ5D5L form, as per your standard policies. We don't require a copy of these screen failure consent forms or EQ5D5L forms. Please also jot the details on the CALIBRE screening log, which we'd request normally every monthly from your site. So please do jot that down on the screening log. Also, the participants that have been randomized, put them on as well on the screening log. So, so once they're randomized, then you follow the appropriate timelines in terms of the visits. And I'll talk about the visits in the later few slides. So I'll move on to the next pathway. So this is in figure 2 of the protocol. So this is very similar to figure 1. However, these participants have already previously had their diagnostic endoscopy, and they have been deemed to have medium or large varices. So they could be potentially, as long as they don't hit any exclusion criteria, be randomized to CALIBRE straight away. We prefer within 2 weeks of the initial index diagnostic endoscopy, but this is not mandated. We prefer it. So it could go over 2 weeks. However, please consult the clinical trials unit and we will advise you if you should carry on or not randomizing these participants. So again, once they're randomized, they fall in the Covidal arm or the VBL arm. The next pathway is in figure 3 of the protocol. This is very similar to pathway 2. However, these participants are inpatient. So these participants have previously had their index diagnostic endoscopy and they are eligible for CALIBRE. However, these are inpatients. So please be very careful when taking consent with inpatients because they may not have the full capacity to give consent. So once you're happy with their full capacity, that they are understanding the questions, understanding that they'll take part in CALIBRE, then take consent. So that leads us to consent, so informed consent. So the participant must sign and date the latest version of the informed consent form. For instance, a copy of the informed consent form must be given to the patient. A copy should be sent to us at Birmingham Clinical Trials Unit, and a copy should be filed in the participant's medical notes. But the original is always kept in the site file. This is just an example of a consent form. So please put your trust logo on the top right hand corner of the consent form. Please try to keep the consent form in one page. Fill in the site name, the principal investigator name, obviously the trial number, which would be given on the randomization. So retrospectively, please put it on the consent form. Please put in the correct version of the consent form. Obviously, over time, the consent form may need to be changed. So currently it's version 3, so that might be version 4, 5, or 6. It depends on what version it is. So always at the bottom of the consent form on the footer, the version is. So please replicate that version on there. The initials of the participants, they need to put initials as opposed to ticks. The participant needs to complete their name, date, and signature, and the person taking consent needs to complete their name, date, and signature. So in terms of randomization, a randomization will be provided by a secure online randomization system developed by our programmers at Birmingham Clinical Trials Unit. Unique usernames are always, we say usernames, but these usernames are always your email address. And the password is the password that you would set yourselves. This is available 24 hours a day, 7 days a week. However, if this fails, for instance, you don't have Wi-Fi access or your computer's not working, so please do give us a call. And the 0800 number, toll-free number, is on the randomization form. So please do call us, and there are dedicated data managers that could randomize on your behalf. So once the randomization form is fully completed, then call us if your randomization system fails online. This is available Monday to Friday, 9 to 5 UK time, except for bank holidays and University of Birmingham closed days. So randomization may begin after participant eligibility has been confirmed and informed consent has been received. A randomization form must be completed before a trial number can be given to the participant. If data items are missing, randomization will be suspended, but can be restarted once the information is available. So please only randomize once your randomization form is fully complete. So this is just a screenshot of the randomization form online randomization system. So the username is always your email address and the password is the password that you set. You log in, and there's instructions for this on the website on how to randomize. So please do go through the instructions. The blue URL is the live system. When you randomize someone, use the live system, and the red is the test system. So please do test yourself how quick it takes for you to randomize someone. The login is the generic login bc2ithelp@adf.bham.ac.uk, and the password is bc2tester2. So please log in with those details, test it. It normally takes around 3 to 4 minutes to randomize someone, probably even quicker. If you have everything there, and over time and experience with practice, people have done it even, the sites have done it even quicker. So in terms of treatments, I've briefly gone over the treatments, and I'll just go over the treatments again. So there's two treatments. The first would be, obviously, it's a one-to-one randomization, so carvedilol, which is a non-selective beta blocker. So participants will be prescribed 12.5 milligrams per day up to 12 months. They will be seen in follow-up clinic at 4 weeks to assess for any short-term adverse events. So obviously the first 4 weeks is from yourselves, and the remaining 11 months is through GP community pharmacy. So please do, after randomization, if they fall in either arm, you send a REC approved GP letter to the GP with the hospital letter that you normally send to GP on what treatment you are giving the participant or the patient. So varicose ligation. Varices are banded at regular intervals. Usually this is 2 to 4 weekly until they are eradicated. After successful eradication of varices, further endoscopies should be carried out as per local trust policies. Any recurrent varices, for instance medium to large varices, are treated with further variceal band ligation, usually again 2 to 4 weekly intervals until eradication, and then offered repeat endoscopies as per local standard practice. So just wanted to talk about treatment modification and crossover. So this is one of our secondary outcomes. So for instance, if a participant has been randomized to carvedilol, they prescribe the first 4 weeks 12.5 milligrams per day, remaining 11 months via GP. If they're intolerant to the carvedilol, then you split the carvedilol to 6.25 milligrams BD twice a day. Intolerant to that, then you reduce the carvedilol 6.25 milligrams once a day. So that's just half a dose. If they're still intolerant to that, change them to another beta blocker as per BSG guidelines. For instance, for the VBL arm, if they're intolerant to the variceal band ligation after randomization, then you could switch them straight to 12.5 milligrams of carvedilol. Intolerant to that, split. Intolerant, reduce. Intolerant, change them to another beta blocker. At any point in time, with the clinician's discretion or the participant's discretion, after randomization, the participant could be switched to either arm straight away, and that is within the protocol. So the participant should not be withdrawn from the trial because of crossover. So in terms of schedule of assessments, we confirm eligibility. That would be done, confirmation of eligibility, that would be done at randomization on baseline. Seek confirmed consent, again, same time point. Randomization, same time point. Medical history, same time point. Medical review, this would be done at randomization baseline. 4 weeks for the carvedilol arm, 6 and 12 months for both arms. And then physical examination, that's at baseline, 6 and 12 months. Office blood pressure, baseline, 4 weeks for the carvedilol, 6 and 12 months. Pulse is quite important, and blood pressure is quite important. These are vital signs, so please put someone on the delegation log to do the pulse and blood pressure for these portal hypertension patients. Standard care blood tests, so we're not requesting for any additional blood tests for CALIBRE. It's just standard care blood test what's available. Please jot that down on the CRFs. Height, weight, administer EQ5D5L questionnaire at baseline, 6 months and 12 months for both arms. The CRFs, dispense trial medication, obviously the first 4 weeks for the carvedilol arm at hospital, and then the remaining 11 months at community pharmacy, which is their GP pharmacy. Adverse event review and evaluation, that's for the 4 week for the carvedilol, 6 and 12 months for both. Adherence, 6 and 12 months for both. The qualitative interviews does not apply, so please do disregard that, ignore that. That's just for the pilot. And then coming back to our primary outcome. So we want to have a look at any variceal bleeding within 1 year of randomization. We have a number of secondary objectives or outcomes. Time to first variceal bleed in days from randomization. This will all be picked up in the CRFs. Mortality at 1 year from randomization. So all-cause mortality, liver-related mortality, cardiovascular mortality. Obviously, mortality would be picked up through a SAE, serious adverse event form. And transplant-free survival at 1 year from randomization. This will be picked up through the CRF. So continued secondary outcomes, adverse events related to treatment up to 12 months after randomization. We're looking at other complications of cirrhosis, patient preference. We're looking at health-related quality of life, such as the EQ5D5L at trial entry, which is at baseline, 6 months and 12 months. We're looking at use of alternative therapies, again, crossover, and patient withdrawal. There's different types of withdrawals here, and I'm just going to briefly go over the types of withdrawals. So the participant would like to withdraw from the trial intervention, but has agreed that data can be collected and used in the trial analysis. The participant would like to withdraw from the qualitative interviews, but is willing to continue with the trial intervention and be followed up. This second one would not really apply because this is for the pilot sites. So any sites going forward, this wouldn't really apply. The participant would like to withdraw from the trial intervention and does not wish to attend trial visits, but has agreed that data can be collected at standard clinic visits and used in the trial analysis. The participant would like to withdraw from the trial intervention and is not willing to be followed up. Only data collected prior to the withdrawal can be used in the analysis. And then data handling. So source data, what do we classify as source data? So we'd say patient-reported outcome data, EQ5D5L form, is directly coming from the patients. So assistance could be given to the participant. A participant could be asked if any data is missing or they haven't completed a question. So you can ask them, would you like to complete the question? But please don't prompt them to put answers in. If they've missed it out for their own accord and they don't want to fill it in, allow them not to fill it in. But this really needs to come from the patient. Lab results, clinical evidence data, health economics data, the qualitative interviews does not really apply, so please ignore that. Recruitment, withdrawal if applicable. So CRFs are all paper-based, so we are not adhering to eCRFs or adopted the eCRFs. It's purely paper-based across all sites. So CRFs are considered complete when all data fields are completed unambiguously or the data is marked as unobtainable. The original or a copy of each completed CRF should be sent to Birmingham Clinical Trials Unit and the original or copy filed in the site file. So this is just the example of a CRF. So please do complete the trial number, the initials, site name, date of the baseline visit, for instance. Please do complete the patient self-declared ethnicity code, and the code is at the back, so please jot that down. If it's missing, then there is a code to put missing or not available. So please do not leave any fields blank. The blood tests are of standard care blood tests, so just fill in whatever's available at that point in time. Most importantly, the INR is very important to calculate our child Pew scores. If the INR is not available, then please do put down the PTT control and PTT patient. So these are very, very important. If you are not able to get the INR or the PTT control or PTT patient, then please do contact ourselves and then we'll advise you on what to do next. So please do fill in all fields. This is just the version control slide. Obviously, the version control slide for this point in time when recording this presentation is correct. In the future, these versions would need to be changed or will be changed. So please refer to the website and contact ourselves for the latest version. At the moment standing, this is as of May 2020. This is up to date, but in the future this would change, so please do consult ourselves and the website for the latest versions and cross-reference with your site file to keep the site file up to date. So data management. Missing and ambiguous data will be queried using a data clarification system, a DCF system. So staff from BCG will transcribe data from CRFs to an online database. So once you send the database CRFs to us, our data manager will be entering all the data on the online system. You would only have read-only access to the CRFs. So in terms of data security, as sponsors, we require the following to be met at your site. So physical security measures, swipe access control for each member of staff, network security measures, system design and management, operational processes, data processing, data protection registration, system audit, and 25-year archiving policy. So as sponsors, we require your site to have a 25-year archiving policy of the site files, for instance. And in terms of audits, monitoring, for instance, we have taken a risk proportionate approach in terms of monitoring. So any continuous missing data, any continuous issues with sites, low recruitment, for instance, then a monitoring visit may be warranted, and someone from the clinical trials unit, either myself or the team leader, may come and visit your site. Ample time would be provided to your sites um, to prepare documents, and we will list down which documents we will um, verify. So, for instance, source data verification would be performed. We'll have a look at the medical notes. We will have a look at the sites file, for instance, consent. It depends which aspect we'll be having a look at or which document. We will let yourself know beforehand, and we'll give ample opportunity and time for yourselves to discuss anything with us before the monitoring visit. This is more of a learning aspect rather than a sort of monitoring. So we want to sort of learn from yourselves on how we could improve the data quality, because the data integrity and the data quality is paramount to any clinical trials. So please do complete all CRFs fully. So quite importantly, the last part of this presentation is pharmacovigilance, which is safety reporting. So I'm just going to go over some definitions. So adverse event, any untoward medical occurrence in a patient or clinical trial subject administered a medicinal product. In this case, it's carvedilol, which does not necessarily have a causal relationship with that treatment. Adverse reaction, any untoward and unintended response in a subject to an investigation or medicinal product which is related to any dose administered to that subject, and the relatedness is determined by the investigator at site. In terms of unexpected, an adverse reaction, the nature and severity of which is not consistent with the information in question set out in the SMPC or the investigator brochure for that product. So the SMPC summary of product characteristics is in the site startup pack. It is also in the site file. So please do refer to that with the undesirable side effects of carvedilol, for instance. This is on an annual basis reviewed, and any sort of changes to the SMPC will be relayed back to sites. We are continuously monitoring the SMPC, and any differences or any additional side effects for carvedilol will be notified to yourselves. At the moment, there isn't any changes to the current SMPC. So in terms of serious, what is serious? These seriousness would warrant a SAE, a serious adverse event form, to be completed. So any adverse event, adverse reaction, or unexpected adverse reaction that I've explained earlier, that results in death, for instance, that results in a life-threatening situation, that requires hospitalization or prolongation of existing hospitalization, results in persistent or significant disability or incapacity, consists of a congenital abnormality or birth defect. Again, going back to one of our exclusion criteria where we're not taking any pregnant or lactating woman on board. If they do fall pregnant, then we withdraw them. However, we follow them up for the outcome of the pregnancy, completing a pregnancy notification form. So in terms of reporting, all adverse events must be recorded in the medical records and reported to BCTU. Adverse events recorded on follow-up CRFs 6 months and 12 months, and obviously for the 4-week carvedilol visits. SAEs recorded on specific form and emailed to Birmingham Clinical Trials Unit within 24 hours. So there are a number of SAEs which do not need to be expedited, i.e. expedited reporting within 24 hours. And these are variceal bleeding, for instance, and other ones. And these are in the protocol. Please refer to the expedited and non-expedited reporting in the protocol. So BCT will report to DMEC, MHRA, and REC as appropriate. So this is just the animation of how the reporting would take place. So for instance, yourself on the left, if it's a non-serious event, then you jot it down on the CRF. This would be 4 weeks for the COVID law, 6 and 12 months for both CRFs. If it's serious, then an SAE form would need to be completed and emailed back to us. Obviously, fax is being or has been phased out on site, so please do email it in the CALIBRE inbox and CC myself, the trial manager. And then once we receive it, I will decide if it needs to go to DMEC, MHRA, or REC. So the first part of SAE form would need to be completed by the investigator, which is the PI, and the second part would be completed by the CI, and the third part would be completed by ourselves at the clinical trials unit. So this is just an example of a SAE form. Please do call us before you submit a SAE form, because majority of SAE forms that come through are non-expedited SAEs or AEs that could be recorded on the CRFs as opposed to SAEs forms. So please do call us and we will characterize and give you the number, not characterize, sorry, give you the number of the SAE via email as acknowledgement. But do call us before you send a SAE form. So urgent reports. All SUSARs, suspected unexpected serious adverse reactions and serious adverse events, must be reported to ourselves within 24 hours of yourselves knowing of the event. So for instance, if a death occurred 4 months back and you only know it today, then please from today, within 24 hours, do let ourselves know. Preferably by phone call first, and then we could decide if it warrants SAE or not. So if it's a death, it would warrant SAE anyway. So the PI responsibilities. This slide is dedicated to the PI. So each PI must read and approve the protocol and sign the delegation log, adhere to the approved protocol, be responsible for only enrolling patients who meet the eligibility criteria. So internal site file, this has been provided to yourselves. So please keep the site file up to date. The eligibility form is the randomization form, paper CRFs, SAE forms, and file notes. Finally, these are our contact details. So please give us a ring on 0121 414 7943 if you want to discuss anything further or clarify anything. Please do email the trial inbox, CCing myself in. Visit the website. The website has all the up-to-date details on university sort of the clinical trials closure dates, any updates. Newsletters will be sent on a monthly basis to sites for yourselves to be up to date on where we are. So please do refer to the website at all times. Any further questions, please do send them by email or do give us a call. Thank you very much, and we look forward to having you on board. And please record any ongoing training on the training log and email back to me. Thank you. Bye for now.